All right. Good morning, PT on Ice, Instagram and YouTube Live, both. I'm Zach Morgan. I am currently lead faculty with cervical and lumbar spine management. Just finishing up the last weekend of the year for spine management, Jordan, having a course over in Charlotte, and then knocking out lumbar spine there in Cincinnati at Onward Cincinnati. So a couple Onward courses to close the year. Spine Division had a great year. Jordan and I had a good time bringing content out all over the country, and we have filled the schedule pretty quickly for next year. So if you're looking for any of our courses in person, we kick the year off January 14th and 15th in Marshfield, Massachusetts, right outside of Boston. And that'll be lumbar spine management. And then at the end of the month in Memphis, Tennessee, so the west side of the state here in my home state, Tennessee, also lumbar spine management. And then February 4th and 5th, Boulder, Colorado, lumbar. If you're looking for cervical, February 11th and 12th will be in Parker, Colorado at Onward, Denver, right there. And then Woodstock, Georgia, right outside of Atlanta on February 18th and 19th, and then March 18th and 19th, another one there at Charlotte. So if you just made that Charlotte lumbar course, make sure you jump into the cervical component. Last piece here on ICE courses is most of our online cohorts start at the beginning of January, so keep your eyes peeled for that. We've got pretty much all of those rolling forward in January, if not Q1. So keep your eyes peeled for any of those courses that you're looking for. But without further time wasted here, let's jump into this morning's topic. So it's Clinical Tuesday, and I wanted to talk a little bit kind of in reflection about the first handful of years of my career and sort of some thoughts I've been chewing on lately about why conservative care should never really be considered aggressive. And obviously, never is a strong word, and perhaps that was a little bit to grab your eyes. Maybe it should be rarely aggressive, but overall, I think we really should not consider conservative care nearly as aggressive as we do. So let me just kind of unpack a little bit about my history. So I started into physical therapy by way of CrossFit. So I was a CrossFit coach at CrossFit Murfreesboro for several years as I was an undergraduate in getting my exercise science degree. And during that time, the real thing that kind of drew me to physical therapy was a gentleman named Kelly Starrett. So Kelly Starrett was is still a famous PT. He owns the Ready State, if you're familiar with the Ready State. And at that time, he was really he was one of the only people in CrossFit that was putting out content that kind of helped you address movement impairments. And I was pretty unfamiliar with that as a coach beyond the things you weren't learning the L1 or just little things that you picked up. But at this time, we really didn't know what we were doing from a movement impairment standpoint too much. And Kelly was putting out daily content. So he would put out a video every day. And in those videos, we would generally, or Kelly would have us do some relatively aggressive myofascial work. So whether it was laying on a foam roller or a lacrosse ball or something that would be relatively aggressive to address that movement impairment or address pain with the movement. And I'll be honest with you, we had great success as coaches utilizing those techniques. And I had great success both personally. So I was able to improve a lot about my overhead position and a lot about squat depth and different movement impairments. But I saw really good success and really good results with that relatively aggressive soft tissue work. And that was kind of how I got interested in PT. So I knew Kelly was a PT. I really was unfamiliar with the profession as a whole. I was a lot more familiar with the strength and conditioning side of things, or specifically the CrossFit side. I definitely became very obsessed with CrossFit throughout undergrad. But as I was coaching that a lot, I was seeing a lot of humans move very complicated ways, climbing ropes, snatching, squatting, deadlifting, you name it. And it was always astonishing to me how durable people were. I remember standing back, and if you've ever coached class, your goal is for your clients to all move very well, but occasionally you're going to look across the room and somebody's not moving well. Somebody has a rounded back, somebody has the bar out of position, and that is concerning from the coaching side. You want to see good movement, but often people would do that and they'd be totally fine, no injuries whatsoever. And so when I entered PT school, the mindset I had was, wow, humans are very durable. They can get away with a lot. And then over the 3 years that I spent in PT school, I really felt like most of what our profession is helping people who come back from an injury or helping people come back from some sort of a health condition that has created inability for them to do the things they want to do, move the way they want to move. And honestly, I felt like that for years we focused a lot on the fragility of humans. And while I understand that, it was important to have those conversations and important to understand that perspective because it's a big part of what we do. I think that my mindset almost shifted from how durable are humans to more of like, oh, humans are a bit fragile. And sometimes as a rehab provider, we start to think people are a bit more fragile than they actually are. Let me fast forward you a little bit to my early career. So, like, I guess blending those backgrounds of kind of CrossFit, Kelly Starrett, relatively aggressive soft tissue work, relatively aggressive exercise. In my early career, I made a conscious effort, knowing that that was my bend or the way my brain worked was to move more towards aggressive interventions. I made a conscious effort to bring my vigor quite down at the beginning of my career. So think utilizing soft tissue work or thrust manipulation or things like that. I had made a consistent effort to bring vigor down, knowing that that was my bias as far as being aggressive. And yet I still continue. I continually received feedback not from patients, but from other practitioners that the interventions I had chosen were aggressive, whether that was aggressive exercise or aggressive manual therapy. I felt as if I was consistently getting the feedback again from practitioners, not patients, that the choices I was making was aggressive. And I guess I started to believe that to some degree because I began to kind of pull back some of the vigor on the dosage of some of those treatments. And I'll be honest, I did not feel like clinical success followed that decision. So withholding some of that vigor felt as if I started kind of being even curious if I was doing anything with patients. Like if I wasn't willing to have them be uncomfortable while exercising, was the stimulus enough to actually create adaptive change? Was there enough vigor of that mobilization to create a movement difference? Was the manipulation fast enough or forceful enough to create a movement difference, to create some of that neurophysiological effect that we're looking for with those techniques? And so over the years, I've certainly blended back towards my old ways with the extreme understanding that you have to know the patient's irritability when making vigor choices. And if you aren't familiar with that, you should definitely jump in either cervical or lumbar because we go into detail on irritability and it's so much more than how much a patient's symptoms rise. It's how fast they fall afterwards. And so treatment decisions began to move more towards, I would say, like vigorous interventions over time. The more I've learned about spinal thrust manipulation, then the more we know, like looking at Bill Reed's studies or some of the Bereznik and McGill work from back in the day, we know that speed and force are factors that create more neurophysiological effect with our thrust manipulation. So if that seems aggressive to go quickly or forcefully, then I suppose I'm a fan of using aggressive treatments, even in someone with relatively severe pain, because you think about who responds super well to lumbar spine thrust manipulation, and it's relatively acute, non-radicular low back pain. Nothing way down past the knee, but mostly just low back, buttock, and posterior thigh. Often those folks present quite severely. They have a really hard time moving. They're very guarded with their movement. And often a fast, forceful thrust manipulation is one of the things that can be helpful to unlock those people. And so I think over time that has changed. And in my mind, I think currently I'm experiencing the best clinical outcomes I have in my career, and that makes sense. As you accumulate um, reps, as you accumulate experience, you expect to get better, and I have found that to be the case. And so there are times now that we'll be dealing with, I would call, relatively sinister pathology. Times where you're seeing a true myotomal deficit, for instance, or a reflexive deficit where in my mind, this is a fairly sinister condition. It's something that we do need to be careful with and really track the asterisks cleanly. But I want to be sure that this human being in front of me is receiving the most aggressive form of conservative care that they can get. And I realize that's a bit of an oxymoron to say aggressive conservative care, but I really do mean that. If we're going to elevate our patients, let's just take down nerve roots, for instance. That's one of the ones that, in my mind, as rehab providers, we definitely want to keep a really close eye on. Is when you have a patient show up that has a true radiculopathy, meaning their hard neurological signs are down. So reflexes, dermatomes, myotomes are affected to some degree. You want to pay attention to that each and every session, but you also want to continue treating that person to see if you can make a difference. Because if you can make a difference in those hard neurological signs, odds are pretty good that you can help this person spare some much more aggressive treatment. So let's think about that a little bit just from that specific maybe lumbar radiculopathy presentation. What are some alternatives that someone might seek out of the PT world? So in the PT world, my tendency is to think about maneuvers like centralization procedures. So be it repeated motions, I would call that somewhat aggressive. They're done at in range. Traction, it could certainly be ramped up to a level of high vigor. Occasionally spinal manipulation. There's a little bit of literature here, and certainly some patients that believe that that will be helpful. So some spinal manipulation in those patients might make some sense. Some soft tissue work surrounding those nerve roots. So whether that's soft tissue work to the back, hands-on cupping, needling, or down like a myotonal needling circuit, or even a perineural needling circuit. These are kind of the thoughts that I have surrounding that pattern of like maybe some treatments I would choose. I mean, if it wasn't that pattern and it was something else like a tendinopathy, you think about a relatively aggressive stimulus for that person. It might be 5 sets of 45 seconds where they hold the contraction the whole time. And so they've got to hold that external rotation for the full 45 seconds, even if it's up to a 5 out of 10 pain. That's fairly aggressive. You're asking this person to hold 5 sets of 45 seconds. You're talking about quite a while of them holding that isometric. And a lot of times they are uncomfortable when they do it. But team, when you do those aggressive interventions, you often see really nice within session changes. And when you see really nice within session changes, you have the components to sell your patient the plan of care that's actually going to help them solve this thing conservatively. So the alternative treatments that people might receive, like for either one of those problems, radic or a tendinopathy, like often people might do some sort of a steroid injection. So maybe it's an epidural steroid injection or just a tendon steroid injection. And then you start thinking about what are some of the potential harms that could come from that. And how does that compare to maybe like the harms that would come from needling, like dry needling, just because those are two similar-ish treatments, both a needle into the patient. But you think about the size of the needle, right? The size of the needle for a steroid injection is quite a bit higher, right? Is a much larger needle. So from a tissue damage standpoint, it's certainly more easy to damage tissue with the larger needle. And then you think about the medication that's induced and how that has effects on the underlying tissue that in the long run often weaken it and make the tissue weaker. You even can see some side effects of things like tendon rupture from a steroid injection. You could see a nerve actually get hit mechanically from the needle and the patient actually end up with more leg symptoms after this. These are all things that I've seen clinically many times when patients have sought those care options first. You think about even something that we think of as relatively innocuous like NSAIDs. Well, NSAIDs have a pretty high GI bleed rate. And I mean, so like some of these treatments that we think of alternatively as if you're going to elevate a patient's care, they might get some of these interventions. Team, these are aggressive. And I'm not even saying that they're not ever appropriate. They might be appropriate for some folks. But at the end of the day, there's no comparison from a vigor standpoint. If you're going to insert a much larger needle and almost saw that through some tissues to get the needle tip to exactly where it needs to be, and then inject a potentially harmful substance into that joint capsule, into that region, that is aggressive. Sinking a dry needle into the region to see if you can modulate pain or maybe improve recruitment, any of those types of things, that's not aggressive. The worst thing that's ever happened for me from an adverse event with dry needling is creating soreness in patients and occasional bruising. So when you compare that to tendon rupture or potential nerve damage or even just long-term tissue health changes with steroids, it's not close, right? We won't even open the bag of surgery. I mean, you think about the difference of actually using a scalpel to open those tissues up and sew them together or do that. That's very aggressive from a tissue standpoint. A mobilization, a quick manipulation, a reverse hyper, an isometric contraction, none of that would be considered aggressive in my mind. Team, I'll kind of wrap things up here with a quick story that is just kind of one of those times that I'll never forget. A few years back, Jeff Moore and I were doing a lumbar spine management course down in Birmingham, Alabama. And this was with mostly a chiropractic group. So a gentleman named John Palmer was the owner of this chiropractic group, and he's the one that brought us in. And so he had several colleagues there as well, some of which worked for him, and then some that were chiropractors from the community. And there were a handful of PTs at that course as well. You guys can imagine that was a bit of an odd course for Jeff and I. I mean, we're typically used to on the weekends spending time with PTs, and people in the PT realm definitely have differences of philosophy, but overall, I would say they're more similar than the PT realm and the chiropractic realm. So it definitely was an odd weekend, but it was a great weekend, and we had a really good time with those guys, and it made us even more realize and believe that our allies are the other healthcare practitioners that don't hold scalpels and pills. Like these folks who are just trying to help their patients just like we all do. And so it was a wonderful weekend, but I'll never forget Jeff and I kind of describing some patients scenarios that we would be uh, threatened to use thrust manipulation on. We would be a bit concerned. And I would say Jeff and I, if you've spent time with us, neither one of us are typically considered to be maybe I think we've both received a lot of feedback that we're aggressive. So it's kind of interesting that we were in this room, and when we kind of described some patients that we thought we might would withhold manipulation on, these guys literally laughed in our face, and they said, "Hey, you guys are missing some serious low hanging fruit here." And essentially, they had a lot of willingness to move into spinal manipulation on a lot of different things that I think we as PTs would be pretty uncomfortable with. And it, in some ways you could sit there and hear that and think, wow, these people are awfully cavalier. It's hard to believe that they'd be willing to use spinal manipulation on those patients. But in other ways, you sit there and realize this is a very busy practice, one that has 5 or 6 chiropractors in it that are all full. Right. And the community in Birmingham overwhelmingly leaves these people very positive reviews about their experiences with them. And you kind of have to sit with that and realize that when the consumer is making the choice that that product is worth it to them, and they're experiencing success because of it, then maybe there's some things that you don't know as a practitioner. And so I remember Jeff and I laughing about that after the fact and just realizing that sometimes the vigor can be a bit higher, and it can be even potentially in a highly irritable patient as long as it doesn't exceed that patient's irritability. And so at the end of the day, I guess to tie a bow on all of this, what I really wanted to talk about this morning is that before you send a patient out and elevate them into what I would consider the medical system, so whether that's an ortho referral or a spine doc referral or even a primary care referral, I think often if we have these patients in our clinic in front of us, we need to exhaust conservative care. And when I say exhaust conservative care, I mean do it aggressively. So that means sometimes that we have to ask people to move through a little bit of discomfort. And as long as that's reasonable and within their irritability, we need to be okay with that. It means if we're going to choose spinal thrust manipulation, we want to utilize the factors that make that treatment most effective. Those factors are speed and force. Comfort, I would argue, is a third. But well researched, speed and force, no doubt about it. If it's needling, utilizing stem, right? We know needling works better with stem. If you haven't learned how to do things like a myotomal circuit or a perineural circuit, you've got to take the course with Paul. I mean, like Paul covers all of those stem parameters and how you might use that in all sorts of different injuries. So I think at the end of the day, my point is we've got a lot of tools in our tool belt to help people with pain. And I would argue we've got more tools in our tool belt that work for pain than any other profession. And we don't have anything that doesn't work. We can't even order MRIs or medications, which at least not in most states. We only do the things that work for pain, but we do have to do those things. And when I say that, I mean we do have to give the person sufficient vigor to where they have a chance at actually making an adaptive change. So that's all I've got for you all this morning. Like I said, we've got a lot coming at you in 2023. So keep your eyes peeled for courses in your neck of the woods. Thanks for hanging out with me this morning. I'll keep an eye on the thread today. So if you have any questions or anything that you want to chew on from a conversation standpoint, let's just make sure we jump into that on the thread. Thanks and have a great Tuesday.